Hello, I'm Miriam Weinstein, and please join me for the following lecture, When a Mark on the Skin Marks a Problem Within, Cutaneous Signs of Systemic Disease. I have no disclosures for the last 12 months of any relevant financial relationships, and over the series of the lectures that I'm providing for this conference, I will have some discussion of off-label use of certain medications. And some of the photos in this presentation are from DermNet New Zealand. What I hope you'll be able to get from the end of this lecture is to recognize key cutaneous features that might suggest a systemic condition and begin to initiate a workup and management as indicated. And the practice change I hope you'll be able to implement is that after this session, you'll be better able to recognize when a common skin finding may in rare instances be a marker of systemic disease. You'll see that most of the conditions that we're going to discuss during this lecture are actually quite common skin conditions. And most of the times when you see these conditions, they really will be limited to the skin. But there are instances when these otherwise common cutaneous only lesions might be a sign of a systemic condition, and that's what we're going to focus on today. I've grouped the different lesions that we're going to discuss into different groups. We're going to start with spots and dots, then we're going to talk about lumps and bumps, and then rashes and itches. Let's start with spots and dots. We'll start with capillary malformations, and these are capillary ectasias that we divide into two groups. One is nevus simplex, and this is also known as angel's kiss or the stork bite mark or the salmon patch, and these are temporary ectasias seen in the usually identified at birth. The one exception is when it occurs in the nuchal area. That's not usually temporary, that's usually lifelong. The second group would be nevus flammeus or a port wine stain, and these tend to be persistent lifelong. If we take a look at the differences between these two common conditions, nevus simplex is much more common, occurring in many newborns, and the three most classic areas would be the nuchal area, the eyelids, and the glabella, although it really can occur anywhere along the midline. These typically fade, as we said, except for the nuchal area lesions. Nevus flammeus is much less common and can really occur anywhere on the body. And these are lesions that typically persist lifelong, and in later teens, or much more commonly when this happens, they can actually darken and thicken, and more commonly that happens in midlife. Capillary malformations, port wine stains in particular, are thought to be caused by mutations in the GNAC gene in some, although not all, patients. So when should capillary malformations, in particular nevus flammeus or port wine stains, when should these present a potential worry that there might be something systemic going on? So there's a few scenarios. One would be in the V1 distribution. 10% of port wine stains that occur in the V1 distribution can have the associated Sturge-Weber syndrome, which can include vascular malformations, not only of the skin, but of the eye and brain as well. Those capillary malformations, port wine stains that occur bilaterally on the face, would have a higher risk of Sturge-Weber syndrome, which the main eye finding that we are concerned about from the ectatic vessels in the eyes is glaucoma and the CNS angiomatosis. And midline lumbosacral capillary malformations may herald underlying spinal abnormalities. I've put in psychological here as a worry sign. Some kids can be very distressed by the visible nature of their capillary malformation, and while not systemic in the same way, it's certainly a worry sign that should be addressed when it exists. And here we have examples. In this patient, we see bilateral port wine stains, and in this patient we see one that involves V1. It also involves V2, but the key feature here is that it involves V1. So what investigations need to be done? For those patients who have V1 port wine stains, ophthalmology at diagnosis, and usually every 6, sometimes 12 months, they need ongoing monitoring. And this is because the glaucoma is not something that we're likely to see or be aware of until it's symptomatic, which is too late. So we can't assess necessarily if they have ectasia in the eyes, and so we monitor for glaucoma. We certainly can do imaging of the brain in these children, knowing that 10% might have associated brain angiomatosis, but it's not unreasonable to monitor these children for their neurodevelopmental status through history and physical exam, given that most younger children who would need an MRI would need one with general anesthetic. If there's no signs or symptoms of seizures or other neurologic findings and development is normal, it may be something that could be deferred. In the lumbosacral area in the midline, if there's a port wine stain, in the early months, an ultrasound can identify if there's underlying problems with the spine. After about 6 months of age, that's hard to see with an ultrasound, and you would at that point need an MRI. However, again, if the patient is developing neurologically normally, they have normal bladder and bowel function and lower limb function, it may be something that can be deferred. Management for capillary malformations, port wine stains, they don't require treatment. Camouflage makeup can be used, counseling for patients who are distressed by the visible nature of their lesion. Those lesions that do become hypertrophic or thickened, again, more commonly that would happen in adulthood, but if it occurs in childhood, or if there's tissue hypertrophy associated or deeper components where it's a mixed vascular malformation that might include venous or lymphatic tissue, there may be a role for surgery. For the port wine stain itself, laser therapy for those who wish treatment is usually the treatment of choice, and in particular, usually the pulse dye laser. Let's move on to another red birthmark, and this will be addressed in more detail in the workshop that I'm presenting. But hemangiomas of infancy can at times herald signs of systemic involvement as well, although rarely. Hemangiomas of infancy are quite common. They occur a little more commonly in females, in premature births, low weight births, and multiple gestation. As yet, we don't know the cause of these lesions. The worry signs for infantile hemangiomas would include obstruction, and this would include things such as periorbital lesions that potentially block vision or threaten to block vision. And hemangiomas in the beard distribution might be a sign for an internal airway hemangioma, and that should be a sign for that. The other associations, again, can be midline lesions, particularly midline on the face or lumbosacral area. They may denote underlying midline defects. And then the one to be aware of, while quite rare, is that hemangiomas that present in somewhat of a segmental fashion on the face, in other words, they appear to occupy a segment, may be a marker for the underlying condition called facies syndrome, which we'll address in a moment. Ulceration can be a worry sign, although not usually one that heralds underlying systemic features. And multiple hemangiomas on the skin can be associated with liver hemangiomas. And we usually look at more than 5 cutaneous hemangiomas as a potential sign for associated liver hemangiomas. Should that occur, we usually recommend ultrasound of the liver. This will show you a hemangioma that is starting to push on the upper eyelid and may well cause ocular complications. And this is an example of a segmental hemangioma on the face. It's quite flat. It is palpable, but it's not one of these thicker plaque-like lesions. But the segmental nature of it would be a potential marker for underlying facies syndrome, which can include, in addition to the hemangioma, posterior fossa abnormalities, arterial abnormalities, cardiac abnormalities, of which coarctation of the aorta is one of the common ones, eye abnormalities, and sternal defects. And these patients require a workup. Most patients, in fact, the vast majority of patients with hemangioma of infancy don't require management. Anticipatory guidance for the family, and then potentially laser or surgery if there's residual lesions left over after regression would be what most patients need. And many of the lesions fade completely and they don't require any follow-up treatment. About 5% of patients, however, will require treatment. And that's either because it's vision or airway threatening, they have ulceration or they're at high risk of ulceration, or we would also treat those that have a significant risk of leaving behind negative cosmetic outcome from stretching of the tissue, and often this includes lesions on the face. Propranolol, beta blockers are our current standard of care treatment for those patients who do require treatment. And we usually titrate up slowly to 2 to 3 milligrams per kilogram per day divided, while monitoring vital signs to ensure they don't have complications. We used to use oral corticosteroids for hemangiomas prior to the discovery that beta blockers worked, and certainly for a patient for whom beta blockers was a contraindication, steroids systemically would be a second-line option. Let's take a look at café au lait macules. These are common congenital or acquired marks on the skin, and many people have one or several of these lesions, and they're increased pigmentation in the skin. They do tend to persist lifelong, although there have been reports of those that can resolve. They're often simply a mark in the skin, probably representing cutaneous mosaicism of the pigmentary cells, but they can be a sign of certain systemic conditions, including neurofibromatosis type 1, Legius syndrome, which is a mutation of the SPRED1 gene, and other syndromes, including McCune-Albright syndrome. There's also many syndromes that have café au lait macules as a part of their clinical or cutaneous features, but not ones in which necessarily the café au lait macules are part of the diagnostic criteria. Neurofibromatosis type 1 is not rare, and neither are café au lait macules. So I think it's useful to keep in mind the criteria that can make the diagnosis of neurofibromatosis type 1, and you need 2 out of 7 criteria for that, including more than 5 café au lait macules that in a prepubertal patient would be greater than 0.5 centimeter, and in a postpubertal patient would be greater than 1.5 centimeters. Family history is a criteria. Axillary or inguinal freckling, which are just very tiny café au lait macules that look like freckles grouped together, either in the axilla or the groin. Specific bony abnormalities, including winging of the sphenoid bone and tibial abnormalities, 2 neurofibromas or 1 deep or plexiform neurofibroma, optic glioma, or leash nodules, which are lesions on the iris. Now, café au lait macules are usually the first sign, and so it often comes to the attention of the pediatric practitioner. And in patients who have more than 5 café au lait macules, it certainly is something to consider NF1, although there are many patients who have more than 5 café au lait macules who don't end up having NF1, but certainly that should be the marker to consider that. It's a condition that's autosomal dominant, but many spontaneous mutations have been noted. There's also some other systemic features that don't form part of the criteria, but are certainly worth knowing about, including a higher risk for scoliosis, an increased lifetime risk of certain malignancies, some sarcomas, carcinomas, leukemia, pheochromocytoma, and neurofibromas becoming malignant. These patients can have some learning difficulties or developmental delay and hypertension. So how do we approach patients who have multiple café au lait macules, and how aggressive should we be in working them up? Well, one study looked at the risk of neurofibromatosis in the presence of multiple café au lait macules. And they found that children under 2.5 years of age that had more than 6 café au lait macules tended to have a relatively high, although not definitive, risk of neurofibromatosis. But children who had already reached the age of 2.5 years and had less than 6 cafe au lait macules actually had a relatively low risk, although not a zero risk. So I think the take-home message from this is if you're seeing young children who have multiple cafe au lait macules, more than 6, they certainly warrant follow-up, and it may, in those cases, be necessary to actually perform testing and a workup, which can be a referral if that's not something that you do in your practice. The other considerations are Leigh syndrome, which is a mutation in spread 1 gene, which can give multiple cafe au lait macules, but not the other typical systemic features of neurofibromatosis type 1. Some patients have very large, often jagged-edged cafe au lait macules, and this can be a sign of certain conditions such as McCune-Albright syndrome, which is a rare condition of hyperfunctional endocrinopathies, and polyostotic fibrodysplasia. We're going to move on now to hypopigmented macules. Nevus depigmentosus is also thought to be pigmentary mosaicism of the pigment cells, leading to a collection of cells that don't produce the expected pigment of that patient's skin. And it shows up usually as hypopigmented macules. They tend to be sharply marginated, and they don't have any scale. I mention that because they often look very similar to post-inflammatory hypopigmentation or pityriasis alba or white eczema, and they can be confusing to tell apart, but white eczema would typically have some scale associated with it. And here we see a nevus depigmentosus, this hypopigmented, moderately defined border, and you can see another one there as well. Now, these are always present at birth, but they're not always noted at birth. And that's important when we explain to families this is a birthmark. They may say, but it wasn't present at birth. So they're there, but they can take several months or even a couple of years to show up. They typically grow with the patient. They're not pre-malignant, and they don't self-resolve. Their real significance is if they cause cosmetic distress for a patient once they're aware that they're there. And depending on the number, could they too be a sign of a systemic disease? We talk about in tuberous sclerosis, the ash leaf macule, which is essentially a form of nevus depigmentosis that's noted to be shaped more like the leaf of the ash tree. As that's a shape that can be challenging to distinguish, really, I think the teaching point is that any hypopigmented birthmarks, any nevus depigmentosis, if there's equal to or more than 3, they should potentially be considered a sign of tuberous sclerosis. And here are some nevus depigmentosis in the shape of, these would be ash leaf macules, and you can see they're a little bit more leaf shaped. Tuberous sclerosis is diagnosed looking at both major and minor criteria. And what I've highlighted in bold here are the cutaneous lesions. They don't form the only criteria for tuberous sclerosis. But in the major criteria, we have the hypopigmented macules we just spoke about, and one would need to have at least 3 or more that are at least 5 millimeters. Facial angiofibromas, which are also go by the name of adenoma sebaceum and typically occur later in childhood, and one would need more than or 3 of those, or a fibrous forehead plaque, which I'll show you a photo of in just a moment. Patients can get ungual fibromas around the nail beds, or the Sjogren patch, which is actually a collagenoma. It's a collagen hamartoma seen typically on the lumbosacral area. Of the minor criteria, there's a feature called confetti hypopigmented skin lesions, and these are, think of them as like very small nevus depigmentosa grouped together. So here we have the fibrous forehead plaque, which is similar to an angiofibroma, but usually grouped papules into a plaque or a plaque on the forehead. Angiofibromas, which can be confused with acne, but there's no comedones. These are solid flesh-colored, firm papules with varying degrees of erythema and telangiectasia. This is one of the periungual fibromas. And this is the Sjogren patch, or the collagenoma, as it's also known, on the lumbosacral area. To make a diagnosis of tuberous sclerosis, a definite diagnosis would be two major features or one major feature and two or more minor features. A possible diagnosis would be one major feature or two or more minor features. And patients who have more than three or more hypopigmented lesions and you're considering them to have a possible diagnosis of tuberous sclerosis, they certainly could be referred for confirmatory testing. An ophthalmologic exam could be done as well to look for the eye features. Patients with tuberous sclerosis in the first year of life can also have rhabdomyomas of the heart, and so consideration for a cardiac workup and echo should be done as well. We'll move on now to lumps and bumps. We'll start with subcutaneous fat necrosis of the newborn, and these are firm, indurated nodules or plaques that can occur in the neonatal period. And I've stated here that they're not warm, and that helps to distinguish them from some of the vascular lesions, such as infantile hemangiomas. Infantile hemangiomas won't be nearly as firm as subcutaneous fat necrosis, although on first look, they sometimes can look similar. And infantile hemangiomas always feel warm. Subcutaneous fat necrosis is usually self-limited. It's not a condition that lasts indefinitely. It takes several weeks to months to fade away. And it's usually seen in babies who have had obstetrical trauma and usually term babies. They may have meconium aspiration, asphyxia, but they usually have some obstetrical trauma. Here are some lesions of subcutaneous fat necrosis, and I've just put arrows so you can see all of these lesions on palpation would be quite firm. We don't really know what causes it. There's some thought that cold or stress injuries in immature fat can cause solidification and necrosis of the fat. They can develop increased non-renal calcium absorption, and this leads to the systemic feature that we need to be aware of, which is hypercalcemia. So in babies with subcutaneous fat necrosis, we would monitor their calcium until the lesions resolved, and if there had been hypercalcemia, until it normalized, usually for a few weeks to a few months. These lesions often resolve, leaving normal skin, but can leave a small scar. They can ulcerate and leave some small atrophy. Warts are a very common cutaneous lesion caused by many subtypes of the human papillomavirus. And while they are stubborn at times, usually our immune system will clear them completely. However, there are some patients who have minor or subtle abnormalities of their immune system where they don't get other classic features of immune deficiency, but they have an inability to clear warts. Now, warts can be hard to treat in the first place, so it sometimes can be a challenge when to determine, should I be thinking about an underlying immune abnormality or are these just stubborn warts? So certainly consider them in patients who have very large warts, patients who have many warts scattered in different places of the body, and patients who are very diligent with treatment, but despite good attempts at treatment and diligence, the warts don't resolve. So here's an example of a very extensive wart. It actually goes much farther down the plantar surface of this foot. One example of such a subtle immune deficiency is isolated CD4 deficiency, very rare. These patients may have other risks for infections, but oftentimes recalcitrant warts are their main finding. So again, just something to think about in the patients who has what you consider to be a really significant number of warts or they're not resolving. These patients incidentally don't have HIV, but they have the low CD4 count from the genetic abnormality. We're going to move on to acne now. Now, most of the time acne is acne, but there can be some scenarios where we may want to think of some underlying conditions. So we divide acne into 4 groups. Neonatal acne, which is actually not acne at all. It also goes by the name of cephalic pustulosis, and it's caused by Malassezia furfur, and it shows up in the first 3 months of life, usually quite early after birth, and resolves by about 3 months of age. Infantile acne is true acne with papules, pustules, closed comedones, open comedones, including nodules, nodulocystic lesions, and the potential for scarring. That doesn't really start till about 3 months of age. It's a cutaneous only lesion. They don't typically have a systemic finding. It's quite rare, but does need to be treated to reduce the risk of scarring. Of course, adolescent acne is typical adolescent acne. So the fourth group that does make us think about other systemic findings is prepubertal acne. So this is acne that may occur somewhere around the age of 4, 5, 6, 7, before the age of 8 in a girl or 9 in a boy, where we would accept pubertal changes as part of the normal spectrum. When we see prepubertal acne, it could simply be premature adrenarche, where the features of adrenarche are out of sync with their other pubertal changes. But we do need to think about other causes of hyperandrogenemia that might have been the cause of their prepubertal acne. And this can include, in very rare cases, androgen-secreting tumors. Congenital adrenal hyperplasia can present with early onset acne, and of course, true precocious puberty, where you would find other findings of precocious puberty and not just features of adrenarche. So of course, this requires a full history and physical exam, Tanner staging, and looking at their growth trajectory. And usually a 17-OHP and bone age would be recommended in these patients, and some would require a greater endocrine workup or referral to endocrinology, depending on your findings. The next lesion to consider is nevus sebaceous. This is a birthmark made out of abnormal sebaceous glands and the associated hair follicles, typically on the head, scalp, and neck. And it's usually a linear or oval pink to yellowish plaque that does not grow hair. It can be very subtle and very palpable, or a little bit more obvious. It's a lifelong lesion that doesn't resolve. And here we see the somewhat oval yellow-red plaque that grows no hair. It's present at birth and grows proportionally with the child. And at puberty, it can thicken. Just like the regular sebaceous glands start to develop, so can the abnormal ones that are part of a nevus sebaceous. So it can become quite warty or thick or verrucous-like in puberty. This can be of cosmetic concern if it's visible. And this shows you at puberty that sort of thickened, more verrucous look of that. There's two scenarios where we would potentially be concerned, and they're both rare. The first is nevus sebaceous syndrome, and this is where a patient has a nevus sebaceous, usually much larger than what I just showed you, and also has associated systemic features, including neurodevelopmental abnormalities and eye abnormalities, and can have other abnormalities of other ectodermal derived tissue as well. Patients with nevus sebaceous syndrome, in addition to having larger nevus sebaceous, it's often on the face and set in a central location. In another rare, although not systemic complication, in less than 1% of patients with nevus sebaceous, they can develop a basal cell carcinoma within the lesion, which would usually present as a non-healing ulcer or nodule. Typically, this would occur in adulthood if it occurs, and it's quite rare. And you can see that there's an eroded nodular surface to the nevus sebaceous. Let's move on to itches and rashes. Let's start with seborrheic dermatitis, common disorder both in babies and in teens who have more of a classic dandruff presentation. This, of course, is a greasy, dry scale, yellow to white, usually diffuse through the scalp, although it can be localized, and can affect the brow, the groin, and the perinasal area as well. It's also caused by Malassezia furfur and can have a component of inflammation as well. We often treat it with anti-dandruff shampoo in hair-bearing areas and an antifungal cream with or without a mild cortisone to facial areas. The condition that this sometimes, or Langerhans cell histiocytosis, is a condition that can sometimes look like seborrheic dermatitis, but is a very rare condition, and it would be something to consider in an atypical case of seborrheic dermatitis. The eruption, in addition to being seborrheic, dermatitis-like, often with a yellowish scale. It can occur in the groin and in the folds where we sometimes will see seborrheic dermatitis. It also often has a petechial component, and that would not be typical of seborrheic dermatitis. This often needs biopsy for confirmation, and patients are usually followed by oncology. And here you can see the eruption in the scalp. There's just a slightly yellowish hue, and here you see that yellow scale in the fold a little bit more obviously, but this actually was histiocytosis. And in the groin as well, it might look a little bit sebderm-like, but that whole eruption was actually non-blanchable, suggesting a petechial component. Another rash to be aware of is atopic dermatitis in the neonate. So eczema usually gets its onset around 2 to 3 months of age. Now, there are certainly patients who can get it less than 2 months of age, but it's something to just think about in the neonate. If they look like they have an eczematous eruption, to consider other much rarer conditions, which can include immunodeficiency that can present with an eczema-like rash, Netherton syndrome, which is a combination of severe atopy, but is actually an ichthyotic disorder, and they can be unwell in the neonatal period with failure to thrive and electrolyte abnormalities. And some malabsorption and nutritional deficiencies can present with an eczema-like rash. With those malabsorption syndromes, though, they wouldn't usually just have the dermatitic rash, which is true of most patients with eczema. They will also often have other features, which can include failure to thrive, edema, diarrhea, and irritability. And this was a patient who presented with widespread dermatitis in the neonatal period and ultimately had cystic fibrosis, as did that one as well. Zinc deficiency is a specific type of dermatitis that, again, can be mistaken for atopic dermatitis, caused either by acrodermatitis enteropathica, which is a genetic inability to transport zinc across the intestinal tract, or from relative zinc deficiency available to the baby. Now, these babies will present with dermatitis, but it's quite specific. It really focuses on the lower half of the face, the acral area, and the diaper area, which is quite specific. And they also will often have irritability, diarrhea, and they can have alopecia. Just to note that if you're running a zinc test, they have to be collected in special tubes, let the lab know, and these patients improve rapidly with zinc supplement. And so here you see that lower facial dermatitis in the diaper area and the acral area, quite a specific pattern. Let's move on to morbilliform eruptions. When would a morbilliform eruption be a possible sign of a systemic condition? Well, if we look at our classic causes of morbilliform or maculopapular eruptions, they include the usually non-specific viral exanthem, simple drug eruptions, and by simple, I mean that they don't have systemic features. They're cutaneous only, Kawasaki disease, and acute GVHD. These rashes can all look identical, and really this is a situation where we need history to help to distinguish them. So what are some possible red flags in an otherwise somewhat typical morbilliform eruption that might let us know that there's more possible significant systemic involvement? Well, if you're looking at a viral exanthem with fever, which is very common, but someone has a travel history, depending on where they travel to, you may want to consider dengue fever, which can often have bone pain and other more systemic involvements as well. If somebody has what you think is a classic drug eruption, but they also have fever and systemic features, this might mark the DRESS syndrome. Patients in this case can have adenopathy, they can have organitis, elevated LFTs, and eosinophilia. And this can be confusing because often the reason a patient was given the medication was for a presumed infectious illness, which may have been a virus. And so sometimes sorting out bug from drug can be very challenging. There are many, many different types of cutaneous drug eruptions, but exanthematous or morbilliform is by far the most common, and it's usually cutaneous only. What we want to note is when should we be worried that it might have systemic features as well. We prefer the term DRESS, drug reaction with eosinophilia and systemic symptoms, to what used to be known as drug hypersensitivity syndrome. And if I were to show you this eruption and you were to palpate it, you would see that it's both macular and papular. This can be simply cutaneous only. So the difference between what we would call a simple drug eruption and DRESS really rests on whether there's systemic features involved. The eruption itself looks very similar. So we think of a triad of the skin rash and fever, which are seen in most patients, and internal organ involvement. And these can start 2 to 6 weeks after a medication has been started. In addition to the morbilliform eruption, which is usually an early feature, they can get some edema with follicular hair follicle accentuation. And sometimes these lesions actually become purpuric. So after a period of time, they stop being blanchable. And facial edema can be a sign, a cutaneous feature of DRESS as well. The most common organs to be involved include the liver, and this can actually have a risk of mortality as well. Lymphadenopathy is very common. They can have pharyngitis and arthralgias or even true arthritis. We certainly look at liver enzymes. CBC, eosinophilia would be common. And if biopsy is required, dense lymphocytic and eosinophilic infiltrates would be seen in the dermis, although biopsy is not always required. Treatment would include withdrawing the medication and trying to avoid any medications of a similar class. Topical corticosteroids can be used for mild skin involvement, and for systemic involvement or more widespread cutaneous involvement, systemic steroids given with a taper are often needed, and we taper slowly to prevent recurrence. And I'm going to leave you here with a list of the medications that have been noted more commonly to cause DRESS, including the aromatic anticonvulsants, sulfonamides, and some of the other anticonvulsants as well. I'd like to move on to facial erythema. There's many common causes of facial erythema that are not a concern and are usually easy to diagnose: fever, sunburn, flushing, eczema, and irritant contact dermatitis. A common, but usually not, we don't usually need to clinically diagnose it, is keratosis pilaris. There's 2 causes of facial erythema that are very rare, but are often concerns. They come up as a frequent desire to rule out, and this includes the malar rash of lupus and rosacea, which is actually very uncommon in children. So just a reminder here of the criteria for lupus. So certainly somebody who presents with a facial erythema, and if you're thinking about lupus, you would want to be thinking about all of these other features as well. The malar rash, of course, is just one feature. And what I want to point out here, and I'm going to show how this distinguishes in a minute from keratosis pilaris, you can see this malar rash is really quite central on the face, involving the nose and the medial part of the cheeks as well. I'm going to talk for a couple of moments here about neonatal lupus, which is very rare, but again, an important one to be aware of. And this really happens from transmission of maternal antibodies, usually anti-Ro and anti-LA, often in a mom who is asymptomatic to the baby, and this causes features of neonatal lupus, which can include cutaneous findings, including what we call raccoon eyes, which are sort of rashes and erythema around the eyes, including the eyes, or these round or oval discrete lesions, and I'll show you in just a moment. In addition to the skin, these patients can also present with hematologic and liver abnormalities and cardiac abnormalities. And one of the crucial things, in addition to diagnosing it for the patient that you're working up, if the mom carries these antibodies, they would pose a potential risk for a future pregnancy as well, and these babies need to be monitored. So if we've made a diagnosis of neonatal lupus, we work babies up for these other conditions. We monitor them. As the antibodies fade, usually the lesions on the skin fade as well, but we monitor these patients usually long term. And here you see these discrete oval, almost targetoid lesions they can get. They can be seen on the body as well as the face. And here's the more raccoon presentation with erythema and eruption around the eyes. The skin lesions, again, usually self-resolve. Corticosteroids can be used to reduce the risk of scarring if there's a lot of inflammation, and these babies are followed, as are future pregnancies for that mom. Keratosis pilaris is a very, very common condition, and this gives perifollicular accentuation, scale, and sometimes tiny little pustules, which don't actually contain pus. They contain degraded keratin from the skin. The most common areas are the upper outer arms, the tops of the thighs, and the lateral cheeks. And you've all seen this pattern before, that perifollicular accentuation. And here we see it again, more close up on a limb. And here we see it on a face. And this is often mistaken for rosacea or the concern for lupus. And in addition to having that sort of perifollicular pattern, they often have some background redness that leads to the mistaken association. But if we put keratosis pilaris next to lupus, I want to highlight that KP is almost always from the mid-face out, whereas the malar rash of lupus usually involves the central face. And finally, a word on itch. We want to think about primary itch in the absence of skin disease. If somebody has an itchy skin eruption, bug bites, or whatnot, we see the primary condition is in the skin. But what about patients who itch and there's no evidence of skin disease? So the first thing you should consider is atopic dermatitis. Even in the absence of rash, remember that itch is primary to the disease. So they may actually have eczema and they're just not presenting with rash at that time. Try to distinguish itching from picking. A lot of parents will say, I don't see any rash, but they're scratching all the time. If you see primary excoriations, but no skin condition, try to discern whether the patient is actually picking or scratching because they're itchy. But if you've ruled out all of the above and there seems to be itching and there's no evidence of eczema and they're not primarily picking their skin, there are some conditions that can cause primary itch in the absence of skin disease, including renal, hepatic, and lymphoma. So certainly in those patients, we would usually do a workup, including blood work, and usually look for lymphadenopathy with a chest x-ray and abdominal ultrasound. And that brings us to the end, and hopefully you will now recognize some key cutaneous features that might suggest a systemic condition and when to consider that in a given patient for what are otherwise often very common skin findings, and have some notes about the initial workup and management as indicated, and that you'll be better able to recognize when a common skin finding may in rare instances be a marker of a systemic condition. Thank you.